Hi CTO Demonettes, welcome back to the CTO Demon channel. Today I'm going to talk about something that is not CTO related. I'm going to talk about my 10 pet peeves for coronary angiography. Those of you who know me know that in my center we used to have 1 or 2 trainees under training at any one time, but recently we've had 8. And with 8 trainees, it's actually quite difficult to get around to explain how to do a coronary angiogram to every single one of them. I did a lecture at the beginning of the year, but it seems they haven't really caught on. And so I'm sitting there trying to teach them, and I'm seeing a lot of recurrent mistakes that they're making that causes anxiety to me and danger to the patient. Now, why am I putting in this channel is because I think a lot of my CTO friends, they are also having to train juniors doing coronary angiogram. And perhaps maybe some guy we're going to come across into the channel and looked at it for out of interest. They may be at the beginning of their training. And this 10 pet peeves might help them do safer and better coronary angiograms for their patients. So it's also a bit of a therapy for me, because as I'm sitting there trying to teach them, when they do these things, it actually causes me anxiety and stress. And I think talking it out is therapeutic. So my demonettes, you are being my therapist today, and I'm unhinging myself, vomiting my ranting to you about my pet peeves in coronary angiogram. So number 1, high femoral puncture. Now, the radial artery is fairly safe. Most of the time, I just let them go on with puncturing the radial. You cannot really do that much damage to the patient through a radial artery puncture. At worst, you could put a compressive bandage on it, and it very rarely gets into any more trouble than that. But the femoral puncture is different. If you have a high puncture, you cannot control the bleed, and you can get retroperitoneal bleed that can be life-threatening to the patient. So, despite the fact we teach them to use ultrasound, to use fluoroscopy, to use micropuncture, the number of high punctures is still very high in our center. I don't understand this. Logically, to me, there's a problem. They often screen at the beginning of the procedure with the artery forceps to see where the femoral head is. And yet when they puncture in, but just as the needle is about to puncture the artery, they don't look again, they just puncture. It's kind of like you're playing darts, and you're spending a lot of time aiming, and just before the end, you close your eyes and you throw the dart. It doesn't make sense to me. You should screen just before the needle puncture to make sure the puncture site is low enough, because high punctures is problematic. Now, there's this debate in our department about what we should do if you manage to put a high puncture and you've put a micropuncture kit catheter in and nothing else. Should you pull it out, compress it, and then repuncture somewhere else and do the case? Or should you pull it out, press on it, and come back another day so that you don't have to heparinize the patient? Now, we had some experience recently. What happened was that we pulled it out and we compressed on it. We did a lower puncture, we checked an angio looks okay. Then we heparinized the patient, did an impeller supported PCI. And of course, in the middle of the night, the patient bled from that first puncture site with a huge retroperitoneal bleed that almost killed the patient. So it's not good. I think if the patient is having an MI, if doing the procedure now has a significant mortality benefit, yes, I think I would probably put a sheath in, 6 French preferably, do the PCI and try to close it with an angio seal and reverse it after the PCI if we have to. It's worth the risk. But if it's stable disease, if the patient can come back another day and it makes no difference to the prognosis, I would suggest we pull the micropuncture set, press on it, make sure it's sealed off, and then come back another day. That's safer. So number 1, high femoral puncture. Number 2, scraping the non-coronary or right coronary cusp. We're nowadays very often doing radial and using a Tiger catheter. Somehow, our fellows always like to jam the J wire all the way deep into the non or right coronary cusp and then push the diagnostic catheter all the way down to the bottom and scrape the right coronary or non-coronary cusp, trying to scrape some plaque off that aortic valve so that it can embolize that plaque down the left main. Not a good idea. And it isn't necessary, because if we're trying to engage the left main, it's usually higher than the base of the cusp. We should push the catheter until it's 2 to 3 centimeters above the cusp and release the J wire. In that way, you don't scrape any plaque off the aortic cusp, and you don't send any plaque down the left main artery, which is a good thing. But it always stresses me because I've seen it happen where, you pull the wire and quite a lot of plaque actually goes back into the diagnostic catheter, and when you inject, the patient has slowly flow down the left side. Number 3, pulling back the J wire until the tip is just outside the diagnostic catheter and start manipulating the diagnostic catheter trying to get in the left main with the tip sticking out. The tip sticking out, when it's not curled as a J but straight, on the end of the diagnostic catheter is actually quite dangerous, and you can dissect the left main or the right coronary os with it. And it gives me this sort of uneasy feeling when I'm looking at this fellow trying to manipulate this diagnostic catheter with a J tip wire stuck out like a sort of sting needle, trying to, like a bee sting, trying to sting the left main. Or sometimes they don't pull back the catheter, they keep the wire in the catheter and manipulate the catheter without looking at pressure. I think the safest way is to not go right down to the cuffs, 2 to 3 centimeters above it, pull back the J wire, connect, check pressure, suck back, make sure you get the air embolism, air bubbles in the catheter, flush forward with contrast and have a little look to make sure contrast fills it well, recheck pressure, then manipulate the catheter to engage the left main. That's the safest way. That's the way I was taught. But a lot of people don't do this. They don't bleed back and flush. And that again makes me very uncomfortable, stressed. Number 5, manipulating the catheter without pressure tracing. They love doing this, I don't know why. Now sometimes it's because they kept the wire in and haven't even connected and they keep manipulating the catheter. The other sometimes is that they pulled it out but they just haven't bothered to connect it to the pressure. They just kept it flat and blood is sucking back, filling back all the way into the syringe, and they keep manipulating. The pressure monitoring tells you that your catheter tip is not dammed against something, it's not jamming against something. It's important information to have and to keep your eye on the pressure monitor when you're doing diagnostic angiography. And that, again, stresses me out. When they're trying to engage the left main, and they're not succeeding at first, very often they will not know what to do. They will keep manipulating, jamming the catheter deep down, pulling it back up, jamming it down, pulling it back up, and it doesn't get anywhere. This frustrates me because sometimes jamming it down, if the catheter is already in the left main, it's going to dissect the left main. So, and they have this habit of taking little flushes without taking a cine, and just enough to see contrast, but not enough to see where you are in position to the left main os. I've taught this again and again. I do the engagement in LAO and RAO. You know, for my 3D wiring stuff, ideally 45 degrees apart, 90 degrees apart, so 45 LAO, 45 RAO. That gives you the best way to cannulate something in 3 dimensions. So in the LAO, actually what you're looking for is how deep the catheter is. All you're doing in LAO is pulling back and pushing forward. And you want to pull back and push forward until the tip of the catheter is at the same level as the left main os. That's all you're doing. But you're not engaged, so you need quite a big amount of contrast, and you need cine to record where you are. Once you're in the right level, you should go to RAO, and then it's a matter of turning forward or backwards. If it's near the spine, then you counterclock the catheter to go back. If it's near the front, you clock the catheter to go forward. It's very important in RAO not to pull the catheter back, because the RAO view is foreshortened. It looks like the catheter is too far in, but it isn't, because you checked that in LAO. So it's very important just to do that, and number of times they don't go to RAO and keep manipulating in LAO is frustrating because it's dangerous for the patients. And number 7, when they do go to RAO, they always pull it back, and of course they cannot engage, okay? So my frustration is with these tiny flushes that they don't do cine on in RAO, so they don't know where they're turning, and they keep pulling it back. Very frustrating. Another thing they do like to do is they put the wire back in when they go to cannulate the RCA. Again, the same mistakes are made. You know, you lose pressure tracing, you can't see pressure damping, and the wire tip sometimes sticking out and trying to jam and stick the RCA ostium and cause RCA dissection. All of this causes me much tension and stress. No, you should first try to manipulate the catheter without disconnecting it to pressure. And if you have struggled, yes, you can use a wire, but that should be a last resort, not the first thing you do, okay? Number 9, they keep trying to engage with the same Tiger catheter despite the fact that it's gone into the conus and damped the pressure 3 or 4 times. Now, I know the first time it goes into the conus, you can try to pull it back a little bit, counterclock a little bit to see if the tip is going to dip into the RCA. But the Tiger catheter has quite a large end bend. And if it goes in the conus, really, it's probably not going to be successful. You probably should switch the catheter rather than risk damping and injecting into the conus, which can cause VF in the patient. So the patient is getting some palpitations, and so am I. So I think at most 3 tries. If you can't get it, you're still getting in the conus, switch for a catheter, a JR4, JR5, MP, longer catheter point downwards. It's safer for the patient, it's better for my blood pressure. Number 10, when they cannot engage the RCA, they are absolutely stumped. They don't know where to go next, and they just spend ages manipulating the catheter. The RCA is an artery that can come off in different positions. It can be low in the cuff, it can be high, it can be anterior, it can even be coming from the left cuff. So if it's a high anterior or a left cuff, you can spend all the time you like manipulating the right coronary cuff. You're not going to get it. So do a cuff shot. Doing a cuff shot gets rid of the 3 main unengageable RCA problems. Number 1, you're in the non-coronary cuffs, you're not in the right coronary cuffs. And in an RAO, you can tell that easily because if you do the cuff shot, the cuff is right next to the spine. That's the non-coronary cuffs. So if you do a cuff shot in biplane, you can tell where you are immediately. And one of the common reasons you can't engage the right coronary is because you're in the wrong cuffs, you're in the non-coronary cuffs, and you can see that clearly from the cuff shot. Secondly, you can see if it's a non-right cuff coronary immediately. So you then go and look for high anterior, then look for left cuffs, so you know where to go next. And finally, of course, if it's a very low takeoff, a cuff shot, you'll be able to see it. And if you're at the bottom of the cuff, you'll be able to see a very low right coronary takeoff, and you can solve the problem. So a cuff shot is the first thing to go to. But the reluctance to do a cuff shot when you cannot find the RCA, the insistence upon keep twirling that catheter around until they twist it and they lose pressure, and then somebody has to go in and snare the tip of this catheter through a second puncture, adding unnecessary risk to the patient. So those are my top 10 pet peeves for coronary angiography. High femoral puncture, scraping the non or right coronary cuffs, keeping a J-tip wire out, not bleeding back and flushing before putting a pressurized tip to find the left main, manipulating the catheter without pressure tracing, not changing to RAO in engaging the left main when we're in trouble, pulling back in the RAO view when we're trying to engage the left main, keeping the wire in the catheter when we're turning to engage the RCA, repeated tries to engage a conus branch when you can change the catheter and make it much safer, and not doing a cuff shot when you fail to engage the RCA. Those are my 10 pet peeves. Tell me what you think about it, and I hope that your frustration through my ventilation has helped you become less anxious and less depressed about this whole thing. And I hope somebody out there can learn these things and make safer angiograms for our patients. Till next time, see you all. Bye-bye.